Good afternoon, everyone. It's my honor to be present today in the meeting. I would like to thank the scientific committee and the organizing committee for inviting me as a speaker. So I was asked to give a short talk about IgG4 disease, and I will take you through my presentation in a short journey, going through the definition and background of the disease, and going through the risk factors related to IgG4, and then mingling through the IgG4 phenotypes and the diagnosis and the current treatment, emerging therapy in the guidelines or in the pipeline. So I have no conflict of interest. So the disease is quite recent. It was just described by Hamano in 2001, so it's almost 20 years old. So we don't have much of literature data related to the prevalence and incidence all over the world. But it was described first as a multi-systemic disease involving different parts and different organs of the body. And with that, the cumulative systemic presentation turned out to be described or finalized as a diagnosis of IgG4 disease. It's mainly involving patients between the 5th and 7th decades of life, and it's mainly predominantly involving males. So, in terms of risk factors, if you look at the literature, interestingly, the literature described the different risk factors related to the presentation. One of them is a genetic, mainly HLA-based and non-NHLA-based. That includes HLA-DRB1, and non-HLA-based including CTLA and alpha-TNF promoter genes that was described in China. Because of the hot topic related to the microbiome, there has been some data related to, sorry, can somebody help me in terms of pointer? I'm not able to use the pointer. I need a pointer. Pointer's not working. So basically the microbiome described. So the microbiome described showed that some propensity of the megasphere to be associated with IgG4 presentation in females. And apparently the disease tend to present in earlier cohorts in the Arabs by 10 years, and the serology of IgG4 was higher, documented in Japanese studies. In terms of occupation, there have been a description of risk factors more in who we call them blue-collar people who are workers who are exposed to metal and dust solvents, and smoking and asbestos exposure is considered as a risk factor for IgG4. Different phenotypes have been prescribed, but the top 4 are the pancreatic biliary disease in 31% of patients, retroperitoneal fibrosis, and head and neck limited disease, which tend to be very resistant and challenging in treatment, and macular syndrome that includes a presentation with a lacrimal gland, enlargement, dryness of the mouth, and narrowing of the fissures. So moving to the IgG4 sclerosing cholangitis, which is the most common, it has an incidence and prevalence of 1.4 and 4.6 respectively per 100,000. That's the Japanese literature. The isolated IgG4 related sclerosing cholangitis can present at 8% of patients. This is an important schedule. I'll ask you to give an attention to it. This is the way or hints that you can use it to differentiate PSC from IgG4. So basically, IgG4 presents more in the elderly, while in PSC can present bimodal, as Dr. Karim mentioned, and in young and elderly patients. Serum serology of IgG4 is high in IgG4 disease. And in terms of an association, it can be associated with different systemic organs, while PSC usually can be associated with IBD. In terms of biliary involvement, the strictures in IgG4-related cholangitis tend to present as a long stricture in the lower biliary system, and I'll talk about it later. While the PSC can present patchy, it can be intrahepatic or any part of the biliary system. In addition to that, the type of inflammation in IgG4 is throughout the layers of the mucosa, the epithelium, without much of epithelial damage. While in PSC, they can present with severe epithelial damage. In addition, they tend to respond to steroids, while in PSC, they don't respond to steroids. So this is an important schedule that can help you in differentiating the diagnosis, which can be sometimes quite challenging. So different classification of strictures have been presented in IgG4 disease, and the commonest one is type 1. So type 1 is associated with autoimmune pancreatitis, type 1 IgG4. It has usually associated with distal CBD stricture, while type 4 has an isolated common hilar stricture and can present in 30% of patients. Type 2 can involve intrahepatic, hilar, and distal CBD stricture, and type 3 can involve a combination of hilar and distal CBD stricture. So, in terms of diagnosis, how do we diagnose? So, it starts with clinical presentation, cholestasis, jaundice, cholangitis, steatorrhea sometimes, obstructive jaundice, followed by serology with elevated IgG4. This can be associated with peripheral eosinophilia, elevated in IgE, and circulating plasmablast, which is a test not available in all centers, but not some research-based center. C3 and C4 complement can be low in patients presenting with renal system, IgG4 related. This is followed by imaging with CT or MRI or MRCP that shows evidence of biliary stricture as mentioned, and followed by a biopsy. The aim of the biopsy is to exclude malignancy, exclude other diseases, and also to confirm the diagnosis. And with the tissue, we will look for staining of the IgG4. So IgG4 to IgG is more than 10 per high power field and more than 40%, with evidence of storiform fibrosis and obliterative phlebitis. Serum IgG4 of more than 135 milligram per deciliter is one of the diagnostic criteria, but it can be normal in 25% of patients. In the literature, a level of more than 333 milligram per deciliter has a positive predictive value of 100%. ANA can be present in 50% of patients. ERCP, EOS brush biopsy has a sensitivity of 20 to 50%, and pulmonary biopsy in type 1 associated with autoimmune pancreatitis can be positive in 80% of the cases. And liver biopsy also sometimes it can be an option for part of the diagnosis. Okay, in terms of diagnostic criteria, so the initial criteria was presented by the American group, the history group or historic criteria, and basically it gathers four main factors or four main parts: the serology, the imaging finding, and the presence of other organ involvement, and the presence of the biopsy that's consistent with IgG4. The presence of steroid was also added as part of the treatment response. This was modified by the Japanese group in 2017, and it had the same factors, but they added the option of steroid as an option in the part of the diagnostic criteria. And the finalized diagnostic criteria was released in 2020, and that include in the imaging, ERCP, MRCP, and intraductal ultrasound, which is one of the new modality that had a good sensitivity for around 60–70%, where it showed a symmetrical thickening of the IgG4 biliary system, while it's more asymmetrical in patient and PSC. So it's good to differentiate between both. And in terms of the other organ involvement, it differentiated, or they put autoimmune pancreatitis as a solo, and other organ involvement that like retroperitoneal and kidney and other organ involvement as another part. So pathology is associated with dense plasmacytic infiltrate, storiform fibrosis, obliterative phlebitis, IgG4 plasma cells, and in some form, which is in severe form in the lung and autoimmune pancreatitis, the arterial involvement can be a part of the diagnosis. So in terms of treatment, the main aim and objective of treatment is to delay the fibrosis, and this is what we call a window of opportunity of treatment. So we want to delay the area to the time that will reach to complication of fibrosis, and the treatment of choice is a steroid. We start with 0.6 to 1 milligram per kg per day for 2 to 4 weeks with a slow tapering over 3 to 6 months. What about maintenance therapy? Maintenance low dose of steroid is administered in high relapse risk patients, and relapse of steroids can reach up to 50% within 3 years of diagnosis. Higher remission is in combination therapy with the use of DMRD. Good evidence and literature has been, with good results, was studied in use of azathioprine, leflunomide, Cellcept, methotrexate, FK506, cyclosporine, and cyclophosphamide. There are also good data in the use of rituximab in refractory cases, and limited data in abatacept and infliximab. So this is the French study that looked at 156 patients in 2017, where they looked at a retrospective patient who got exposed to rituximab at least once in their lifetime in IgG4 related disease. So they found out that the overall relapse-free survival was higher, with a mean of relapse-free survival between 30 to 50 months, with the higher relapse-free survival in patients who have mild disease than patients with severe disease with IgG4 related index of more than 9. And patients who had at least a maintenance, 1 dose of maintenance therapy of rituximab had very high, with a good relapse-free survival of up to 50 months. So the overall clinical response rate was almost 93%, and the steroid withdrawal was around 51%. So this is a very important slide that gives you an idea about how does it work and how does the emerging therapy and the pipeline are in the treatment. So the concept of the IgG4 disease works on and relies on the activation of the T follicular cells. It works on the mature B cells with maturation that will result in stimulation of the plasma cells to IgG4 positive plasma cells to stimulate the fibroblast to initiate the fibrosis. So throughout this axis system, there are different axes where mechanism action can be interrupted, and different medications currently are in the pipeline and are being studied. So different medications, as I mentioned, are currently in the pipeline, are being studied, but I'm going to move to the publication or the abstract that was published in EASL, and it was published in New England Journal of Medicine, where for the use of enedazilumab in patients with IgG4 disease. So this is a study called Mitigate trial. They looked at on the enrolled placebo-controlled trial, where they enrolled 135 patients with a background history of IgG4 disease. 40% of them had a pancreatic involvement, 19% had biliary duct, and 3% had a liver disease based. So they randomized them to placebo versus inebilizumab. They had 3 doses, day 1, day 15, and week 26, with a quick tapering down of steroid at week 8. So the overall risk of disease flare was reduced by 97% in patient in the pancreas group and 100% in the patient with the biliary duct group. The adverse event was minimal. So basically, appendicitis, fibroadenomyopathy, and hyponatremia. And in conclusion, analysis of IgG4 disease with pancreatic hepatobiliary involvement demonstrate the benefit and safety of CD19 B-cell depletion by inebilizumab. So IgG4 disease-related response index is one of the modality tools to assess the disease behavior for every patient over 28 days. That includes the assignment assessing the disease damage, the organ damage, steroid response, and the IgG4. And it's a good tool to stratify the risk of the disease and the severity of it. So prognosis, high risk of hematological solid organ malignancy, especially in patients with in patients with multi-organ involvement, high IgG level, high IgG4, and high eosinophils and IgE, those are high risk for hematological malignancy, and those patients, they benefit actually for long-term maintenance therapy. In my conclusion, window of therapeutic opportunity is the recommendation with early treatment to prevent any complication. It's important to differentiate PSC from IgG4. An updated diagnostic criteria was released in 2020 as a good tool for assessment. New therapeutic drugs in the pipeline for treatment of IgG4 disease. Thank you.